Hey team, welcome back. I'm Sean Heverson. In this discussion, we're going to be continuing on our lecture that we previously reviewed for spinal trauma. So far, we've covered some of the anatomy and patient assessment principles when managing patients that have spinal trauma in the pre-hospital setting. Now, this video is for paramedic students, and in the next version or the next lecture, portion of this lecture, we're going to be talking about mechanisms of injury that result in spinal trauma. So let's explore those. The most common cause of spinal cord injuries comes from generally high energy forces that are translating that energy into the body. But lower energy mechanisms of injury can also impact the spine, especially if it's placed directly over the spine, or if it's impacting patients of special populations like the very young, the old, and those with other considerations like the pregnant population. Now, most of the spinal cord injuries statistically that we see come from things like motor vehicle collisions, significant falls. Penetrating injury makes up about 15%, which is interesting because penetrating injury has to essentially follow a very specific path through the body to make its way to the spinal cord and cause trauma. Sports injuries and a combination of contact sports and high velocity sports contribute to this, and everything else falls within the other category. Spinal cord injuries impact not only the livelihood and life and quality of life of individual patients, but it has an impact on our overall healthcare system, on the family members that have to care for these patients long after EMS is gone and they've been discharged from the hospital and they go through rehab, and so on. So we want to make sure that we recognize these and can manage them appropriately to prevent further damage from happening. When somebody has a mechanism of injury that potentially can damage the spinal cord, the severity is dependent on two factors. Number one, what part of the cord is actually injured in the process, what we'll term as our primary cord injury. And then second, what's the damage to the nearby structures like, and how does that impact the function of the underlying spinal cord? Now, the spinal cord itself doesn't necessarily have to receive all of the trauma. We can have injuries to bony structures or supportive connective tissue and soft tissue of the neck, for example, or instability of the vertebrae that can make the spinal column less likely to be able to resist any further injury and perhaps cause injury to it itself. Violent impact to the head, torso, or pelvis and neck is generally one of the initial stages of us considering that somebody has a spinal cord injury. That transition of energy generally happens within the region of the spinal cord. Some of the transitions of forces can include sudden acceleration, where, say, a patient is moving from a slower point now rapidly accelerating to a faster point, perhaps where they don't have protection for their head to move against those forces, rapid or sudden deceleration. And then like lateral bending forces to the neck or torso can also contribute to this. So we might see this in car accidents like what we in layman's terms might call the T-bone accident. Falls, especially those from significant heights, can lead to spinal cord injuries. Ejections from vehicles or motorcycles or other vehicles can result in patients receiving spinal cord trauma and other trauma as they travel through the air and land. They may have associated multi-systems trauma or head injuries as well. And then a very kind of typical EMS scenario for isolated spinal trauma might involve something like shallow water diving. Now, blunt force trauma can generate large amounts of energy transitions into the body in general. And with blunt force trauma translating to spinal cord injuries, one of the things that likely happens is the energy from blunt force is translated likely to the head or to the neck, and the movement of the head then causes the spinal cord to be impinged. And certainly there's a wide variety of how blunt force trauma is applied, but we find that in motor vehicle collisions, more than half of spine fractures in that setting are from blunt force trauma, according to PHTLS's 2020 edition. Almost 50% of C-spine injuries from blunt force trauma result in unstable cervical spine, which would require us to stabilize if we want to prevent further damage, like the inability to breathe or becoming a quadriplegic. Now, when managing patients that have blunt force trauma, especially that to the neck or head, we are certainly considering spinal cord injury and assessing and managing, but there also might be at the same time head injury that's a comorbid factor now with this patient, then going into certainly another system and presenting with its own set of challenges, which is linked to another video. I'll link it here on my screen, linked to another video that we've done on traumatic brain injuries. When managing patients that we have a mechanism of injury that has a high index of suspicion for a spinal cord injury, we generally want to presume that we have spinal cord injury and an unstable spine in these circumstances. One, blunt MOI, or mechanisms of injury from violent forces that impact, as mentioned, the areas where the spine travels, head, neck, torso, and pelvis. And remember, the pelvis is attached to the lower region of the spine where the quadratus equina is, so it can certainly damage the spinal cord, even though it's at the very terminal or lower end of it. As mentioned, sudden acceleration or deceleration, lateral bending forces to the neck or torso, like we might see in motor vehicle collisions, falls, especially in the elderly, or falls from great height in any patient population, motor vehicle collisions that are coupled with an ejection in some type of powered transport, whether that's vehicles that have gas power or somebody riding a bicycle down a hill and being ejected from it. Shallow water diving, as we mentioned before, and significant helmet damage when we are pairing this with both motor vehicle collisions, human-powered vehicles, and in incidences of, say, construction and or industrial accidents, and then certainly also those incidents with contact sports. Also, we want to associate this with blunt force trauma when the person has head injuries with an altered LOC. And part of this is because with their altered LOC, this may be a distracting injury from the patient being able to describe the pain they have and the sensation they have that would cloud then our ability to get symptoms and to diagnose the underlying spinal cord injury. Significant blunt forces to the torso can result in trauma to the spine since it's traveling in the posterior portion. Impact or deceleration fractures of legs or hips probably came with large amounts of energy that were also translated to the pelvis and the spine. And then localized forces to the spinal column. And this could be something that has a low velocity, a low amount of energy, if you will, translated to the spine, but it's done so in a particular area that allows all of that energy to impact the spinal cord or the spinal column directly. Penetrating trauma is a little bit different, and there's a few things to consider about penetrating trauma. Whereas in blunt trauma, we generally have a high index of suspicion for spinal cord injury. Penetrating trauma really depends on a couple factors. So the penetrating trauma may not produce the amount of movement or force that translates to the body that a blunt force trauma in the same location might. Partly because if we have penetrating trauma, then we have to have generally a surface area that's small enough to cause penetration through our skin, bone, and other cavities, and the amount of energy that's needed to do so. So when we have penetrating trauma that impacts areas around the spine, or is traveling into the body and its trajectory impacts the spine, that's where we find some of the penetrating trauma associated with spinal cord injury. So it really has to be essentially an association nearby in proximity with a combination of the amount of power or energy translated and trajectory. Another portion of this is to remember in a very specific example, if a patient, say, shoots themselves in the head with a handgun, for example, let's say this person unfortunately attempts suicide and shoots themselves in the temple, when that occurs, the patient's head is going to move somewhat because of the explosive forces of the gun. But generally, just by itself, if that GSW is impacting the head, it probably didn't cause enough movement of the head to cause the spinal cord to be stretched or impinged in the process of movement. So we don't necessarily always need to provide C-spine precautions in patients that have, say, a penetrating GSW injury to the head. You do need to assess to make sure it's not present because it's not going to be completely absent 100% of the time, but the likelihood is a little bit lower that the patient will have an associated spinal cord injury along with penetrating trauma, especially with GSWs to the head. Now, impaled objects present some of their own problems, of course. Impaled objects, if they're impinging or impacting the spinal cord directly, or if they're not allowing blood flow to reach the spinal cord, could present a mechanism that results in a spinal cord injury. Although, in addition, just in general, when managing patients with impaled objects, a question for you, do we generally remove the object? right? And what considerations can we remove the object? In some cases, it's not necessarily moving the object, it's removing the person from the object, like those that were maybe ejected from a vehicle and then impaled onto a fence post. We're not necessarily going to remove the patient from the fence post. We're going to remove the fence post and take it with and probably impaled in the patient. So what are the conditions in which we can remove an impaled object? So generally, to be able to, and this is not specifically for spinal cord injury, but removing the object is only really permitted when we have a situation in which the impaled object is interfering with airway or interferes with CPR. So essentially, if it's going to impact the patient's ability to breathe on their own by the placement of this impaled object, or you're not able to perform CPR and you need to, those are the only two real indications to remove an impaled object. And the reason why you're probably familiar with is that the impaled object may be itself providing essentially a tourniquet or a blockage of blood vessels that are right up against this object. So imagine we've got this impaled sharp object here and a nearby blood vessel was cut by the impaled object. The blood vessel is probably resting right up against the object, and that is providing a tamponade or a tourniquet, which is preventing internal bleeding from occurring. And if we remove it, bleeding is going to suddenly resume, and the patient will probably decline rapidly. So the impaled object in some cases may actually be saving the patient's life. All right, in this diagram from Jones and Bartlett, I really like to highlight this diagram because in this diagram you get a lot of information at once, and it's visual, but we have to probably break it down a little bit. So let's go through some of the descriptions here. So the E end and the F end here are describing flexion and extension. A reminder of what flexion and extension mean. They're the movement of joints. When we're talking about a joint has an angle. And in this case, the joint is going to be the angle between the jaw and the anterior neck, right? So essentially right there. So in measuring an angle and its movement, we use terms flexion and extension. So if we're decreasing an angle, right, moving so that we make the angle of the joint smaller, decreasing the angle is called flexion, right? So in this case, flexion, to describe the movement of the neck, is when the chin moves downward. That's flexion. Extension is the opposite. Extension is when we increase the angle at that joint. So for our purposes, extension here is going to describe the movement of the head going essentially backwards. And that's what our descriptions F and E and the associated arrows here are for. All right, also on this description, we're seeing compression with a C and distraction with a D. Compression and distraction are two opposite movements. So distraction is when we have a pulling force that essentially tries to separate the head from the torso. Compression is when the head moves closer to the torso, and a good example of compression is when somebody is shallow water diving. Now, along the spectrum, you can see that we've highlighted with the inner arrow injuries that are usually stable, and with the outer arrow, injuries that are usually unstable. So let's walk through some of these. We'll start with our compression fracture. So when somebody dives or lands on their head, remember that the head is traveling until it stops on the ground. All right, this person diving forward, their head is going to travel along with their body until it impacts the ground. So the head impacts first. Then the body is still traveling towards the head because it hasn't stopped yet. And as that occurs, the head is stopped in position, the body compresses or pushes the vertebrae close together, and in that compression can cause fractures of the vertebrae. The fractures of the vertebrae then become bony fragments and allow for injuries to the spinal cord, to blood vessels, to the meninges, and to the structures around the vertebrae as well. As we move towards degrees of flexion, so this first would be essentially flexion plus compression, where we have the head moving downward, the chin moving downward while compression occurs. And that can happen when, say, somebody is traveling in a vehicle and their head hits the windshield and their path of travel here's our steering wheel, when their head hits the windshield, their chin moves downward, but the body still is continuing to travel until the neck compresses and stops where the head stopped on the windshield. With flexion injuries without compression, we end up essentially impinging the anterior portion of the vertebrae. And when that occurs, we can allow things like discs to slide backwards. We can fracture the anterior portion of the vertebrae, causing bony fragments. And when we have the disc move, that's a particular issue in which, if you recall from our AMP discussion, the discs or intervertebral discs are made of cartilage, and they're donut-shaped, essentially, sitting in between each vertebrae. And the spinal cord travels in a very specific hole in the center that doesn't have a whole lot of room for movement. So if our spinal cord, here's our spinal cord, is traveling through an intervertebral disc, and the patient has, in this case, abnormal flexion, the pinching, this is anterior and this is posterior, the pinching of those vertebrae will cause the disc to slip backwards. And when it does so, now my disc is moved to this position, we'll say, it's going to pull on the cord. And remember, the cord doesn't have a lot of flexibility in it, so when it pulls, it generally starts to tear individual neurons and other structures of the spinal cord. Here we're seeing, in this circle, we're seeing the combination of a little bit of the patient's distraction and flexion. So we won't have as much impingement in the anterior portion, but it can cause fractures of those vertebral bodies, which essentially hold the stability of the neck together. The distraction injury comes from a set of particular circumstances or mechanisms in which the head is pulled away from the neck. And often this is illustrated when somebody is strangulated or suffers a hanging. When the patient has something around their neck that is going to put pressure on the bottom of the neck and allow the body to hang freely, that person's whole body weight now is pulling the spinal column down away from the head as the head sits in its position. So, hundreds of pounds are now exerted pulling the spinal cord apart. And this shows a significant amount of distance between the vertebrae, which should be pretty close together with the intervertebral discs. And in doing so, we probably are pulling the cord along with it. And so that creates a unstable injury. Now moving backwards towards the extension. Now as the head moves upwards and we have forces now pinching in the posterior portion. So in this spinal picture, here's anterior, here's posterior. What we're showing are combinations of the vertebrae bending towards the back and kind of pinching at the rear, in which we may have some forces where the disc can slide forward, similar to what we had here, just a different direction. We can also have the vertebral processes or the spinal process, which you actually palpate when you're feeling somebody's back in the pre-hospital setting. They can fracture as they get pinched closer and closer, and in doing so, those bony fragments become potentially points where we can cause spinal cord injury. Now, injuries of extension tend to be usually stable in their presentation. So in this one picture, we get a variety of movements of the neck, and their likely mechanisms can be associated with them. So what I'd encourage you to do is, as we go through some of these specific mechanism pictures in the next few slides, go back to this image and try and figure out what's happening to the neck within this circle of movement. Remembering that flexion is moving the jaw downward, extension is moving the jaw upward. So a good example of extension or hyperextension, too much extension, is when somebody has a condition like whiplash. All right, let's go through some of the mechanisms that result in the pictures that we saw on the previous slide. So axial loading is to describe when we have a load of energy, when the loading of energy and weight is going to be down the center line of the vertebrae. So if we have our vertebrae here of the neck, anterior and posterior, axial loading is when we have loading of pressure directly down the center where the spinal cord is. And so axial loading comes from examples. The best example, I think, is to describe when somebody is jumping into shallow water and they strike their head on the bottom of the pool or the water source, and as their head strikes, the body continues traveling. And it's traveling straight towards the head along the spinal column's axis, and so that would give us axial loading. So if we go back to our picture here, axial loading will result in compression. Now, when the patient is traveling, they really well illustrate the multiple stages of any collision. If you remember back to kinematics, we described that when there's an accident, when there's a collision we generally have multiple stages of impact. And so first the car impacts something, then the person impacts the stopped car or the steering wheel, which stopped when it hit the front portion of the vehicle. Then when the person's chest, say, strikes the steering wheel, the heart is still traveling and their internal organs are still traveling until they strike the chest wall. And so those are the stages of multiple collisions. This is similar. The first collision will be when the head strikes the ground. The body is still traveling, and that compresses the spine specifically. Now, because of this can generate fractures of the vertebrae, can cause damage to the intervertebral discs, and can cause significant injury to the patient's spinal cord. Here's a diagram from the textbook that describes vertical compression as resulted from this. So with axial loading, we probably have the loading moving from the top towards bottom. And if we have a person falling on their butt, though, the opposite of the previous description of somebody diving head first, if somebody falls and lands on their butt, they can have the axial loading up the spine as well, beginning at the lumbar. Mechanisms of injury that result in axial loading include motor vehicle collisions, especially when a patient is unrestrained and when they are traveling and have their first impact with the vehicle. Their first impact with the vehicle is when the head strikes the windshield. Now, when the head strikes the windshield, the head can go a few different directions. The head could flex and go upward, it could extend and go upward, or it could flex and go downward. But the point where the head strikes the windshield and the body's still traveling behind it results in axial loading. Sometimes the patient is restrained by striking the windshield and they don't travel any further, where in this case we have the starred windshield pattern to represent the head striking the windshield, a significant indication that we may have head and spinal cord injuries as a result. But sometimes the windshield doesn't stop the person and they result in being ejected. And so the person may be ejected and strike the windshield first, where they have one instance of axial loading, and then as they travel through the air and strike the ground the second time, or the second impact when they strike the ground, they may land on their head and have another instance of axial loading and other sources of trauma. If somebody's on a motorcycle or a bicycle, they probably won't be striking a windshield. They'll be traveling up and over the motorcycle handlebars and then landing, potentially striking their head in a very similar pattern to that of shallow water diving, but probably at significant speed and striking probably hard objects. All right, so a bit of a warning. We'll talk about some situations that are certainly not pleasant for anyone involved and can serve as a trigger. So when discussing a distraction injury, this is essentially the opposite of axial loading and can result in the cord being stretched so much as the head likely stays in place and the body and body weight start pulling the spinal cord apart and pulls the spinal cord apart, resulting in a tear of the cord. Now, there may be other injuries associated with this as well. So distraction may be one of multiple injuries that are present. How does this occur? Well, a common mechanism of injury for distraction is when somebody has been hanged. And this can originate from someone attempting suicide or from murder, but can also come from accidental injuries and motor vehicle collisions as well. Unfortunately, with kids, an example of how a distraction or accidental hanging might occur is a child on a playground getting their head tied up somehow in a structure that allows the body to hang and tear the cord. Could also happen in a home where somebody has blinds that have the strings to allow you to pull them open and closed, and they haven't been pulled up out of the way, so the child gets a hold of them and wraps them around their neck, and as a result is hung. Now, distraction can occur, but in addition to the pulling of the cord, we might also see fractures of area C2. And this is specifically from the result of hanging, where the body weight has caused a fracture in the neck. And remember, with our vertebrae C1, C2, C3, it's very, if not impossible, difficult to assess these because they're very deep in the neck and kind of occluded by our ability to palpate them by the occipital region of the back of the head. And so you're going to have to utilize essentially your CSI goggles to get a picture like we have here in this CT or X-ray, and then be able to kind of assume based on the mechanism that this may have happened. And again, we have to identify these injuries very early on so that we can provide appropriate C-spine precautions. Flexion injuries, again, back to the movement of the angle. So the angle of the neck would normally be probably like this. We're reducing the angle when the chin moves downward. And in this case, we're depicting a person who's striking the windshield. So their head was traveling this way and then turns downward with flexion. So we can have compression and flexion, which we saw was an unstable fracture. A common description of this is the result of a motor vehicle collision as the head moves forward and strikes the windshield, but can also result in rapid deceleration or be the result of rapid blows to the back of the head in which the head flexed down rapidly and probably unbeknownst to the person, so they didn't see it coming and didn't prepare themselves. Rotation with flexion adds another portion to this injury. And so in this picture, we're showing that the person has flexed the head, so the angle went down, but their head is rotating from one side to the other or from center to one side as this is occurring. So we get a combination of some types of compression, but at the same time, we may have injuries to C1 and C2 as the head turns and the compression accumulates at the base of the skull, impacting C1 and C2. So this is generally going to result in an unstable injury. And again, we don't see this play out. We have to utilize our clues and description of the car accident to understand that this occurred. The patient may not remember that their head turned as they struck the windshield. This is a picture of hyperextension. Hyperextension can start off with injuries at the lower end of the spectrum, like low-level whiplash, in which perhaps only soft tissue around the neck and spine has been injured, but the spinal cord itself has not been injured, but can be extreme and cause injuries to the spinal cord as well. So again, if our angle here would be normally like this, we're seeing a larger angle as the head extends. So hyperextension is generally the result of someone getting into a car accident where they don't have a headrest or the headrest isn't properly sized and likely are probably struck from the rear. So as the vehicle moves forward, their body moves forward in the seat, but the head ends up staying backwards and gets extended. Lateral bending is also a concern. Lateral bending occurs when we have, as mentioned, lateral car accidents or the T-bone accident impact. And kind of imagine essentially where a person might be sitting down in the vehicle. And in this picture, we've got a strike right essentially behind the passenger front seat. When this occurs, what ends up happening is, forgive my crude drawing here, but here's the seat. We'll say here's the door that struck, so the forces are going to come this way, and our person is sitting here. So as the vehicle strikes, the energy is first going to tug on the torso, and the head will stay in place. The head then starts to move opposite the impact injury, so the body's moving this way, the head is moving this way, and the neck can turn. This can also result in the head striking glass, causing the potential for traumatic brain injury or striking other objects like the other vehicle's hood if the forces are strong enough. And so this can result in the patient having what is termed as a subluxation injury from that movement of the head. Now, those are the major mechanisms of injury associated with spinal cord injuries.